Hello, I'm Sarah Day, Policy and Research Manager at the HFMA, and you're listening to HFMA Talk, the podcast for NHS Finance. This episode focuses on the West Midlands. Outside of London, the Midlands is where Covid-19 has had the biggest impact in the UK, and within that region, the West Midlands has been worst affected. But there is still a wide variation. We are going to hear two different West Midlands perspectives. A fairly rural community view from Ros Preen, Director of Strategy and Finance at Shropshire Community Health NHS Trust, and an urban acute view from Susan Rollason, Chief Finance Officer at University Hospitals Coventry and Warwickshire NHS Trust. So without further ado, let's speak to Ros Preen. Hello Ros, thank you so much for joining us today.
Hi Sarah, it's a pleasure.
So first of all, could you start by describing your trust? So where in the country you are, what you do and your population that you cover?
Yeah, sure. Our trust is Shropshire Community Healthcare Trust. We provide county-wide services to the population of Shropshire. So that's based in the West Midlands and it borders onto Wales, Herefordshire, Staffordshire, Wolverhampton, just to give you a sense of where we are. We're the largest inland county in England. That's our kind of claim to fame. And there's some very rural aspects of our county. So the population we serve is around 500,000. And I suppose the thing that we note all the time is that we've got a higher than average percentage of our population over 65.
So how is Covid-19 impacting your area at the moment?
Well, we're currently, and I hesitate to say this because it will be very different compared to other parts of the country, but we are actually faring better in Shropshire than other areas, and I'd say particularly in the West Midlands when we look in comparative terms. So the impact of Covid-19 at the moment, our infection rates per 100,000 of the population is fairly low, and that's in comparison to more densely populated areas. So we'd consider ourselves at the moment very fortunate, but we're not complacent. So just to give you an example, the real kind of hot issue at the moment that we're experiencing is the rising issue with regard to care home infections. And that's very much echoing the national trends that are being reported in the media. So our focus right now is how we respond to that and what support we can provide.
And how do you get involved with the care homes from your trust perspective?
Well, there's a couple of things which I suppose I could share with you. The first thing is a very direct response, which we're working with primary care on, which is multidisciplinary teams to support care homes. So that was something that was in the pipeline anyway and was part of the PCN developments, but we're working on that to put that in place in real time now. So that's one thing that's really engaging some service redesign and implementation for our community teams. And the other thing which we are expecting to happen pretty soon, I'd say within the next week, is that because there's a review of discharge pathways from the acute hospital going on at the moment in response to care home readmissions back to care homes, we're looking at organising how we admit to our community hospital beds, which is a slight modification to business as usual. And whilst at the moment we've got capacity in our community hospital beds, we're expecting that position to change significantly. So we've been gearing up our community hospital beds to support the care homes.
And did you see any changes in demand before then? I'm assuming that when the acute hospitals had to start finding space, it put some pressure onto your services.
Well, interestingly, we've had a bit of a calm before the storm, I think, Sarah. We've been looking at the demand and also our capacity to make sure that we could be as flexible as possible and use all the facilities that we've got. As we sit here today, we've actually got a number of our community beds vacant and empty, which is why I refer to that kind of calm before the storm. I think we've been through a profile where obviously our acute colleagues have been closing down their elective work, focusing on their urgent care and COVID care. And because of the position we've been in, which I said earlier has been relatively fortunate in terms of the incidence of COVID-19 in the county, we're only just starting to see the flow through now. So some of that elective care changes actually has meant we've had less admissions through that route into our community hospitals for rehab and reablement. So it's given us a little bit of breathing space to prepare ourselves properly. So, for example, we're geared up with 80 beds that have got oxygen supply to them if they're needed. Those sorts of things took a little while to set up and put in place for support to the acute sector. So we've been quite fortunate. We've had some breathing space with regard to our community beds. So perhaps not what you were expecting as an immediate impact. Like I say, I think we'll have a secondary flow now coming through because of what's happening in other sectors. The other thing that we've found, and again this has been reported nationally, we run the county's minor injury units, and we've done a significant, very rapid piece of work to move the urgent treatment centres away from the two main hospital sites and relocate them alongside our minor injury units. And the reason we did that was because the activity has fallen to numbers on one hand in a couple of locations. And I know nationally there's been a concern, which we share locally, that actually people just aren't accessing. They don't want to come into a hospital site like they would do normally. So we're keeping an eye on those services as well.
I believe there's been a national discussion around what core community services should be during this time, and I wondered if you could tell us a bit more about that.
Yes, you're absolutely right, Sarah. Very helpfully, our regulators were really quick to publish national guidance on how we should prioritise community services. So that has been a great guide and helps and supported our business continuity planning. And then we've also had a standard operating procedure to follow. So that's become our business continuity guide. It's allowed us to assess which services we should stop, partially stop, amend or continue. So it's allowed us to work through all of our sort of service portfolio against the backdrop of some national guidance. So we've now got a service directory that guides our decisions about where we place our workforce and how we've redeployed, taken some decisions around training, and it's given us a really good corporate record to we're absolutely sure what our service position is in every service, and allows us then to plan for the recovery phase as and when. So that's been a really helpful sort of supporting piece of guidance that we've been using locally.
And what sort of things have you had to stop doing for the moment?
Well, the main, apart from we provide some services that would be under the banner of elective care. So we do some MSK services. We have, I suppose, the biggest impact has been in our children's services. So health visitors, school nurses, etc., which you can imagine have had to really consider what service they can provide while schools have been closed. And those nurses have temporarily been redeployed. But actually this week we've started to have a look at putting back some of the services in those areas because we're recognising that actually the support to things like safeguarding needs to be enhanced. So they're the kind of things that we've stopped or amended.
Okay. And in terms of the services that you're still delivering, how has COVID-19 impacted how you deliver them? I'm assuming that home visits have become more complex.
Yes, they have. I think the biggest thing the positive thing that I would point to, and this is a positive in terms of the future as well, is that we've deployed some technology very rapidly, two pieces of technology that allow video consultation, which I know in some areas would be standard practice, but was something we hadn't quite got an agreement locally as to which technology we were going to use, etc. And we've very, very rapidly taken those decisions and implemented. With some support from our regional national colleagues, actually, it's been really helpful to have some technology sponsored nationally and said, get on and do it. So we've got on and done it. So that's really helped accessing vulnerable patients via technology. We have a very mobile workforce anyway, and this hasn't impacted particularly because all our clinical services are geared up to work remotely. So we've not seen a huge impact in terms of how our staff work in terms of what they've got to enable them to do that. It's just they've had to think very carefully. I mean, obviously, all the kind of issues around PPE and things like that apply where there has to be face-to-face contact, and we're doing all the clinical swabbing and testing for the county.
How are you working with primary care? Have you had to pick up some of the services that they would traditionally have been delivering?
I wouldn't say directly picking up, Sarah. I'd say that the collaboration around our community teams and primary care has just had to get a lot tighter. So that's again something that we have been working on with various kind of programs and pilots and things over the last 12 months to enhance that integration with primary care, and we've had to step that up in a really significant way. The multidisciplinary team to care homes I mentioned earlier as an example of that. So again, I would say our primary care colleagues would describe their workforce as fragile, but not at a point where they can't operate. So we've been working around primary care with them, with our local authority colleagues in a way that we've been piloting before, but it's just happening now. Which is really good to see.
And as you say, a similar story with your local authority colleagues as well.
Yeah, I mean, it's great really. We've had I suppose 18 months or so of working in small-scale pilots in multidisciplinary teams. That's created the basis or the foundation of some good working relationships, which obviously we're using now in real terms. I mean, what's interesting is almost immediately we've kind of suspended our STP programs and the governance around our STP and switched to a much more clinically led resilience planning, pathway planning set of arrangements and working groups. And I suspect, and this is, I suppose I'll try and predict this, I suspect that will be a much more productive sort of route to getting things done than we've had previously. So it'll be interesting to see when we come out of this phase whether we actually stay with what we've got now, because it's working and it's engaging clinicians in a very different way, or whether we go back to the STP structure. And I'm sure we'll all be reflecting on things like that, won't we, in the future?
Yeah. So have you had to change your organisational governance as well as your STP-wide arrangements?
It's been interesting. We had to do a real kind of step back and just test out whether our governance was going to be fit for purpose. So obviously we've all, I suppose, make the point that maintaining good governance is still really important even in a crisis. So on that basis, we've got a bit of a framework where we've had to put in an audit trail around instant decisions that need to be made on the day, rather than something that can wait for a committee or the board meeting. So we've added to our governance, but still made it very, very transparent. So, but most of our processes and governance are still fit for purpose. We kind of, if we were checking out, we're pretty digitised anyway as an organisation. So, we can still get stuff done, which is great.
Excellent. And what are your finance team up to? Are you all working remotely, or is it a mixture? Are you doing other things?
The finance team have been brilliant. I'm really, really proud of them. I mean, they're a great team anyway, and they always look out for each other. That's just kind of standard practice for them. So when we had the instruction to work from home if possible. They work really hard with our IT guys to establish almost 100% remote working, and they really, almost within a day and a half, they'd moved out of our head office and were working remotely. Wow. I've been testing out, various things that are coming in through the inbox, and I'm like, how are you getting that done? Is that because we've got somebody back in the office who's sending you stuff? But actually testing that out, a lot of our systems and processes have switched to remote, to being done remotely. So there's some lessons there for the future. And we're still aiming to get our accounts in at the earliest date, which just shows how effectively we've been able to embrace the kind of new way of working, and it hasn't knocked them off the track.
Well, that's excellent news. And how are you working as a team and supporting each other? You mentioned they're very good at doing that, but obviously now everyone is quite isolated.
Yeah, so we're using Microsoft Teams, which, lots of people have switched to using that, and it's a really useful tool. So we're holding team meetings, and we're looking at a range of wellbeing support as a team that have been put into place locally. So lots of opportunity there to just check in and make sure that everybody's okay. And you'll be pleased to know that they're also looking at the HFMA for the range of support that you guys offer and the advice that you provide. So that's also something that they would naturally go to, a place that they naturally sort of refer to. They've got always build in humour into their conversations, so there's always quite a light-hearted kind of approach to aspects of the team meetings, even though we're doing them remotely now. There's lots of evidence that they're looking out for each other and checking in. So as I said, they're a great team, and I am really proud of them.
And are you starting to think yet about how you get back to normal, or whatever normal might be in the future?
Yes, yeah, we are. And the finance team this week, we're looking at wellbeing and how we might, what we might retain. What we're learning, which is just, again, it's fairly kind of standard practice for them, because they're always challenging themselves in terms of what could we do better. So there'll be loads of things that we'll probably should change. Some are fairly obvious. The Teams aspect, remote meetings, etc., really works for a dispersed organisation that's spread out throughout the county. So I'd be really disappointed if we weren't using Teams in the same way. And there'll be some stuff that we haven't thought about yet. So that's something that we'll continue. So we're having early conversations, not just within the finance team, but corporately as well, because I think we're all now, this number of weeks in, starting to either see the benefit or being able to reflect in a way we weren't. If you'd asked that question a couple of weeks ago, we were probably all still trying to settle down and work out how we were working. So I think over the next few weeks, there'll be more thought, more determination put behind some of those things as we, like you say, head towards, hopefully, a new normal, whatever that is.
Ros, is there anything else that you'd like to add?
What I've seen over the last few weeks, and it's that point about building on relationships, I think we'll come out of this pandemic phase with a greater degree of trust and appreciation of what everybody does. And I think we'll be more confident with each other to make things happen. I think that's one of the things, a kind of, relationship based change that we need to make is, critical, I think. And I just think we'll have built up some confidence through experiencing this, because we've just had to do stuff, regardless.
Everything's happened so quickly. We've had to ignore sort of traditional roles almost and just get on with things, and that has helped with those relationships.
It has, and I suppose, again, just The moving out of our urgent treatment centres from the acute trust into our accommodation to sit alongside the minor injuries units is something that we have discussed as a could do item in the county, and we did it in a matter of a week and a half, and we've got clinicians rubbing shoulders with each other now, which I'm sure will produce something different again. But it was just, well, we'll just get on and do it, and nobody really put any barriers in the way. It was amazing to see, and that involved quite a lot of different disciplines, not just medics, nurses, X-ray, pharmacy. It was great, and everybody pulled together to make that happen. So I was really heartened by that. That was a really good piece of collaborative work. And I'm sure everybody could probably point to an example of something like that happening in their area.
Thank you so much for your time today, Ros. That's been really interesting. I really appreciate hearing your perspective on COVID-19 and how it's impacted your trust. Thank you.
And thank you, Sarah.
From rural Shropshire, we now move to Coventry and hear from Sue Rollason about the impact on the acute trust there. So hello, Sue. Thank you so much for joining us today. Could you start by telling us a bit about your organisation and the population that you serve?
Absolutely. I'm the Chief Finance Officer for University Hospitals Coventry and Warwickshire NHS Trust. We've got two sites based at Coventry, a university hospital site, and a smaller site at Hospital of St Cross Rugby. We are a large teaching trust. We're also a major trauma centre and a specialist tertiary provider of services such as renal transplant. And we serve a population of over 1 million people, and we deliver over 800,000 episodes of care to Coventry, Rugby and beyond.
And how is COVID-19 impacting you at the moment in your area and for your trust?
So I think COVID has touched everyone and every area. From a service view, we've had to rapidly prioritise our most urgent services and patients to ensure the hospital is best placed to manage the surge of hospitalised COVID patients. We've had to scale up our ITU capacity, retrain and redeploy staff at speed. We've had to transform many of our services, delivering vast numbers of outpatients, either in virtual environments or by telephone, changing our discharge processes, and really working together as a system to ensure we can operate our cancer services and some of our specialist services. We're really conscious as an organisation that there are also many urgent conditions that we need to continue to treat. And I think really, as well as just the service side, it's actually touched individuals. So a lot of our staff and the people who work at UHCW are also part of the local community. So it's clearly touched them and their families across the whole area.
So how have you changed the way you do things in order to deal with the pandemic?
So I think it's worth saying that we've been connected to the Virginia Mason Institute for 5 years now, and over this time we've really embedded our own UHCWI service improvement and management methods. So we've used this for some time to deliver our transformation programmes. But I think in terms of the impact to the trust and how we've managed the impact to the trust, this has really come into the forefront of the COVID crisis. We've used our production boards for daily management, and we've set up new ones for things such as protective equipment. I think it's enabled us to have really quick process mapping for new pathways and visual control systems. And also, I think above all, it's given us a really good cultural place from which to respond to the crisis. In terms of our actual hospital at the moment, our COVID numbers are now starting to stabilise and decrease both in terms of in and out of ITU. But I don't think anyone's complacent here, and I think everyone's acutely aware that this is the start of the journey.
And how much have you had to increase your capacity by? I've read that the Midlands are one of the most affected areas outside of London.
Yeah, so in terms of our actual planning, we'd actually got a multi-stage and multi-phased approach in terms of increasing ITU. Actually, we've only really got up to the second stage in terms of our surge plan. So we really only doubled our ITU capacity. But in terms of the planning stage, we had to think about certainly tripling that capacity to business as usual, which has taken a huge requirement in terms of retraining, looking at actually what that means in terms of workforce and also equipment, of course. So looking at ventilators, looking at oxygen supplies, etc. I think we've been quite fortunate that we haven't gone into the very highest stage of that surge plan. But in terms of the preparation, we were certainly ready for an even bigger surge than we saw. Of course, everyone now talks about where we are and it being stabilised, but we're quite conscious that actually the lockdown and how that now is lifted is a significant component and will have a significant impact as to whether there'll be a future surge that we need to accommodate.
So your business continuity plans, then, have they been effective? Have you learned anything that will change how you do your emergency planning in the future?
So our business continuity plans have worked really well. And I think over and above this, there are definitely some standout people, both within my team and outside of my teams, that have gone over and above to make sure things work. And I think I can't thank those people enough. I think hindsight's a wonderful thing, but we tend to think about continuity plans in quite a siloed fashion. So certainly, we assume if there's a high proportion of a department that's sick, then we write our plans to assume another department can step in. But when that question of sickness rates is high across the entire hospital, then clearly we need to change a lot of our processes. And that's something that we don't necessarily consider when we write those plans. And at the same time, of course, we had to move to virtual teams and different processes all at the same time.
So you've had to change your governance processes somewhat then?
Yeah, we've had to change our governance processes, but I think the most important thing to remember is that we've maintained our governance, and certainly in terms of our chair and non-execs, they've really worked with us to strike that balance between understanding the challenges but nevertheless maintaining governance and scrutiny. So I think in terms of how we've changed them, we've moved to virtual sign-off processes where needed rather than hard copy paper. We've extended our signatory lists where there are single points of failure, and we've made decision-making processes faster. My aim at the start was to make sure that we didn't slow down important decisions, but at the same time, we didn't lose sight of our key accountabilities and responsibilities. As a trust, we have a decision log and critical decision tool of all decisions taken. We link this to finance to ensure we have a clear audit trail and sign off. So I don't think we've taken out governance steps as such, but we've changed them to accommodate the current situation. We actually turned to the HFMA briefing as well as a finance function, and we turned that into a checklist to ensure that we hadn't missed anything.
And how is your finance function working? Is everyone still at the hospital, or are some people working at home?
Yeah, so we've got a mixture actually. So when I first started out, and when all of this first started out, I wanted to make sure that everyone was quite clear on what the expectations were during this period, but also that they felt supported. So we've got a mixture of people working off-site and remote, and we've also got some people actually within the hospital. And we're trying to strike that balance between teams actually social distancing and limiting the number of people on site, but also maintaining a level of management visibility at the hospital to support the clinical colleagues. I think when you're a finance team in an acute hospital, you don't just want to step away. We have a daily team huddle via a virtual platform, and this is cascaded through every team. I have a department brief this week, and it's great because the technology allows you to share the presentations and notes as well as interact. We've had a staged approach to redeployment within finance. So the first thing is really to maintain our essential finance services. So particularly around some of those financial services. So we've had financial managers retraining to ensure that financial services continue and we can continue to pay people and continue to pay suppliers. But also then in terms of making sure that we can do our key accountabilities and statutory duties. So certainly, as all things, COVID hit us in the middle of annual accounts. So we were quite aware that we needed to maintain that duty and maintain financial staff to undertake annual accounts effectively. But then over and above that, we've really looked at where we can release people from our finance function to support the people in the hospital. So I've had a transformation team, I've had some of my financial managers moving PPE stock around the hospital and looking at the stock take and ensuring that we've got a really robust process in terms of PPE. So I think it's really been a mixture really. So we've had people working on site, people working off site, and also people doing different jobs as well.
And you mentioned about paying suppliers promptly and supporting businesses at this time. Is your supply chain working? Is it quite resilient?
Yeah, we haven't had too many issues around that. I mean, one of the things around our continuity plans, I mean, to start with, the continuity plans, we needed to also assess some of our suppliers of our financial systems in particular to make sure that we wouldn't have any issues in terms of financial systems continuity, because that would be a real problem for us. But over and above that, yes, we've tried to put in additional processes to make sure that we comply with prompt payment. We were quite conscious of the national direction as well in terms of ensuring that that supply chain and the cash, if you like, continues to flow.
So at the moment, everyone is operating on block contracts, which is obviously a very different way of the finances being managed for your sector. What do you think that might mean for the future, for how the finances work in the NHS?
So I think that's a really good question. And I think if you were to ask many people at the moment, they would say that they wouldn't want to go back to necessarily the old financial regime. So I think I would just add one comment. So for UHGW, our main commissioner, Coventry and Rugby CCG, for 1920, we actually operated under an aligned incentive contract. So we didn't operate a PBR, a payment by results type contract anyway. So in some ways, the block contract arrangements actually aren't that dissimilar to the main contract that we held with Coventry and Rugby, albeit that ours was very much around having shared ambition for delivery targets and capacity alignment and all of those things, as well as just an amount of money. Because I think it's really important to acknowledge that an aligned incentive contract is more than just the pound notes. It's about the whole way that you operate. I think in terms of the start of the year, we know that we will be operating under these block contracts. And I think that that's certainly taken out and will take out a lot of transactional noise. And I think it will be that balance now to look at how that will move forward. And if I was to predict how it would move forward, or how I would like it to move forward almost, I think it would be around that aligned incentive. So moving from what is just a straightforward block contract to something that's more sophisticated than that, but actually making sure that we are rewarded for doing the right things now in the system, and that actually there's flexibility across the system within systems. I think one of the key things over and above just the block contract that this crisis, if you like, has really catalysed is the need for system working, but also the fact that when you take out some of those financial conversations, you get far greater movement between organisations and pathways. So I'm just thinking about some of the things that we've introduced at really high speed around discharge processes and mental health processes, for instance, that actually I think the first principle is actually the crisis has given everybody a focus to do that. But secondly, I do think there's something around the financial framework allowing you to have a different way of operating and not to worry so much around where that cost materialises in an organisation.
Yeah, so the way you've worked the system has changed as a consequence of the pandemic, and probably for the better.
The irony of it is, I'm the system finance lead, and I think we've probably undertaken in however many weeks, and it hasn't actually been that long, more transformation in those past few weeks than we've probably accomplished in the past couple of years. And I probably shouldn't say that, but it's true. Yeah. And I don't think that our system is dissimilar to a lot of systems. I mean, if you look from the transactional side around looking at how you deliver outpatient attendances and using digital platforms and virtual platforms, but also looking at actually where core services are actually delivered and how you align that within your health economy. And I think also, as I said, looking at when we've expanded social care packages, actually that's enabled much faster discharge. And I think that's something that you wouldn't ever want to go back from. So we now need to see what we want to continue going forward. And the same again for mental health. The way that we've operated mental health services has been in a very different way. And I think for all of these things, though, there's a reset. So it's not just about, everyone talks about restoration, but actually it's not really around restoration now. It's around reset. So we need to look at what's been successful and actually where do these lines now, how do we decide now what continues, what gets put back to how it was before, but importantly, what gets reset completely and we do things in a completely different way.
And are there things that you've noticed as you've been going along where you would like to make some significant changes to how you operate in the future as a consequence of what you've learnt?
Oh, absolutely. I think that's at every level as well. So I think, service delivery level. So I've talked through some of the major service changes that we've had. And certainly that partnership working has enabled us to discharge people out of our secondary acute unit in a much more effective way. And I think we're now thinking about how we join teams and look at joint posts to enable that to continue into the future. But also I think we're looking at how, we may invest in different parts of our sector so that actually we get people in the most appropriate place. And that doesn't necessarily need to be in the big acute. It can be outside of the big acute. But also even things within the hospital that, things around the way we meet, the way we do meetings, the way we actually communicate to each other. We now realise how much time we lose just travelling back and forward to different venues. It sounds quite a simple thing, but, through the power of technology, we have a daily huddle with all my finance team, so we work through a virtual platform and that enables us to keep in daily contact, but it also enables us to have a really good audit trail of all the things we've agreed as well. So I think there's some really big benefits that we need to capture and not lose, at the end of all of this. And let's be honest, we don't really know when the end of this is anyway. So, we need to start to think about how we transition into what is the new norm.
Absolutely. Thank you. Many thanks to Ros and Sue for sharing their thoughts on how Covid-19 has impacted their organisations and what can be learnt from the NHS and wider system responses. We greatly appreciate you both finding the time to speak to us. The HFMA is providing regular podcasts throughout the pandemic, covering a range of areas. If there is a particular aspect that you would like to hear about, then please let us know. All of our Covid-19 related briefings, blogs and news articles are openly available on our website, hfma.org.uk. There is no need to be a member to access these, so please tell your colleagues. We have also launched an online forum where finance colleagues from across the NHS can discuss issues and challenges in a safe space. You can sign up via the link in the network section on our website at hfma.org.uk. Thank you for listening to HFMA Talk. Don't forget to subscribe to this podcast to keep up to date with new episodes.